Procedure. Yes, Dr. Vinod, please.
Yeah, thank you, sir, and good morning to all of you. Uh, Here we'll show you some videos and we'll discuss something how to manage in the same sitting the nucleus drop or cortical metal drop with the iris claw lenses. So the incidence rate of a nucleus drop or any cortical matter is about 0.3 to 1% of the cases. Uh, how much experience you are, that sometimes it does not matter. Even these are the few risk factor in such cases. Even you have done thousands of surgeries or lakhs of surgeries, sometimes you face these challenges, how to handle these cases and prevent the nucleus drop. So like prior vitrectomized eyes, because during past planar vitrectomy, sometimes lens touch is there, and after cataract, you don't know the whether posterior capsule is intact or there is some tear during the vitrectomy. So you have to be very careful. You should know about your cases very well before starting the surgery. And general compromise, pseudo exfoliation, floppy iris syndrome, hypermature, posterior polar cataract and complicated cataract. These are the few conditions you must examine properly and then proceed with great caution and attention, because the next complication which we will see after this nucleus drop or cortical matter drop or iris coming in the anterior chamber, those are the serious complications. Like there is a corneal edema, high intraocular pressure, vitreous hemorrhage, cystoid macular edema, and retinal detachment. So these are the very serious complication, and sometimes you are not able to handle those edema and detachment and vitreous hemorrhage, and you and your patients are in anxiety till your patient does not have good vision outcome. So please take precaution before proceeding such cases to avoid such complications. So first thing, as early as you have your experience, with experience you can see whether PCR is not there or not. As soon as you have the signs, a few signs, you can manage it easily and early, so further complication will be avoided. Like you have a sudden pupillary constriction while during hydrodissection. This is called a pupil snap sign. Maybe a sudden deepening of the anterior chamber. You feel difficulty in rotating your nucleus due to the rupture. Sometimes vitreous comes in the back, so you're not able to rotate it properly. You may feel tilting of the nucleus. So these are the few early signs. If you recognize it, you can manage it very nicely and very easily without creating further complications. So if it happens, now how to proceed after the nucleus drop, after PCR? You can, after PCR you can still hold your nucleus and prevent it going back to the vitreous. Like put your tip of the phacoemulsification away from the capsule by another instrument behind your tip or behind the nucleus, and after being extracted from the posterior chamber, the nucleus needs to be emulsified in the iris plane. Try to take it out anteriorly, or with little section hold the nucleus anteriorly and take it in the anterior chamber. If it is soft, you can manage it there in the iris plane. If it is hard, better to convert it into the SICS and take it out through the anterior route. That is a more easy and more less complicating. So few points are they necessary you should know and follow. So you can do a very good anterior vitrectomy even you don't do the pars plana also. Like you have to create a closed chamber first of all. Reduce your bottle height. By reducing bottle height, you reduce the irrigation, the flow of the irrigation. When the flow is less, though your vitreous does not get more hydrated. If flow is more and your cannula is towards the posterior pole, so more vitreous will get hydrated and more vitreous will come anteriorly while doing anterior vitrectomy. First thing is the reduce the flow rate. And second point is use the maximum cutting rate you have in your machine, 8,000, 10,000, with the minimal or moderate level of the vacuum. Vacuum should be low and cut rate should be the highest. It will not create the pulling of the vitreous and will cause a less stress on the retina. So these 2 points should be kept in the mind while doing anterior vitrectomy. So, while managing your nucleus drop with the iris claw lens, as already has been mentioned by our prior speaker, that is very safe, very speedier, very convenient, easy. Anyone can do. Even the residents are doing very well. If you have some few tips and guidance, you can start with the iris claw lenses without any before any special training, not required. Very less learning curves. One or two things are there that your anterior chamber must be clear of the vitreous. No vitreous tag should be in the pupillary plane. No any distortion of the pupil should be there. Make sure that your AC is free of the vitreous. And you have a sufficient iris support. So these retropupillary iris lenses are so good now, have a better design that they does not create much complication like even the increase of IOP and the cystoid edema and loss of the iris tissue. So it's very easy and it gives you very good result. And when you are putting it through the scleral tunnel, that is more best way to go through the scleral tunnel instead of increasing the corneal incision. So atrophic iris, already told me, it should be avoided. Here are the few cases we will see. There was a nucleus drop, and as a conventional pass planar 3-port 23 gauge vitrectomy is being performed here. Whole nucleus inside the vitreous lying on the retina. So a good vitrectomy should be done before taking out your nucleus. It should be free of the vitreous. No pulling of the vitreous should be there. With the help of your light pipe and suction, you can take it anteriorly and put it in the anterior chamber and can support it with your light probe so it does not go back, and very easily you can take it out from the SICS incision. And then again you look for the vitreous cavity, is there any complication? And you can see the very good round pupil is there. As already technique has been told, you must keep in mind that your tunnel, side port tunnel should be at the limbus. It should not go more in the cornea. So you will be able to fixate it in the periphery of the iris. That is one point. And the two ports should be 180 degree apart. If they are sideways, you will feel difficulty with the inclination. You will have a difficulty in your angulation of the hand. The second case is the IOL drop. Foldable IOL drop is there in the vitreous. Induce the PVD and do a good vitrectomy. Your vitrectomy should be up to the periphery, maximum vitreous you can remove. No indentation is required to do vitreous base saving. Just while picking up the lens, no vitreous tag should come in the way. And very easily you can hold with the IOL holding forceps, 23 gauge micro forceps. Put it in the anterior chamber. And again look for any break or tear before closing your case. And you can see 180 degree apart, and very gently you can slide your IOL in the AC and make it horizontal before holding with the forceps. Do not hold with the forceps and then make a horizontal. That is difficult. First make it lie horizontally, and then you can hold with this forceps which have a broad base. With the broad base, your lens does not rotate. It gives a good grasping. And very easily you can inclavate. You will feel jerk in your hand when it is inclavated. And if you don't see on the slit lamp, no one can tell that it is a posterior chamber IOL or it is iris claw lenses. Here is a case of aphakia. Some cortical matter is left in the AC and behind the iris. There was no matter in the vitreous on the retina, so I did not do pars plana vitrectomy. Simply anterior vitrectomy, we can clear this cortical matter. And with this iris repositor, you make sure that your iris is free from the any vitreous tag. You can see a round circular pupil. Even if you don't have a triamcinolone at that time, you can make sure that there is no tag. With this iris repositor, you can swipe all around the iris, below the iris and above the iris in the pupillary margin. So we have a good round pupil. Thank you.
Thank you so much, Dr. Vinod Kumar Singh. As we have demonstrated very nicely, this is a message for you that patient has so much high expectation from you, and once the patient has planned for the surgery, and this kind of situation may arise, it happens. It may happen with any time. It is well-reported fact, and certain predisposing factors are also there. In that situation, if you face this kind of picture, then you can't postpone. And then patient not going to listen anything except he want to know, listen that yes, this surgery is excellent, and then the next morning and the evening patient will get the vision. So you have this in such of cases that the same sitting, in spite of so much complication, patient definitely will get the vision the same sitting. So as a primary procedure, this retropupillary is definitely better option, one of the best option. Thank you so much.
One more point I would like to add. While inclinating the second side of the IOL, while you are holding your IOL with the forceps, you should pull little bit of the lens anteriorly towards your port, because while you are holding the lens, your superior iris is dipped downward, so you are not sure that it is covering whole pupil or not. So you can put little pull towards yourself, then inclinate it. Then the whole pupil will be covered with the IOL. Thank you.
डॉक्टर विनोद, ये बताइए, आप इतना जल्दी करते हैं, ये फास्ट वीडियो किया हुआ था कि इतना जल्दी हो जाता है?
सर, अब आपकी कृपा से जल्दी होने लगा है.
वेरी नाइस, थैंक यू.